Hi everyone, thank you all so much for listening today. My name is Cassie Rush. I'm a second year pharmacy resident at Children's Hospital Colorado, and I have the privilege of reviewing sickle cell disease with you. I have no relevant financial relationships to disclose, and we will not be covering off-label uses of medications. I'd like to acknowledge those who took time to review these slides and make sure that this presentation was optimal for your learning, including Drs. Ashley Sabis, Amanda Cadmus, Emily Rowe, and May Bell. Here are a list of abbreviations for your reference that will be used throughout the presentation. Please feel free to go back to them at any time. Our objectives for today include to describe the epidemiology and pathophysiology of sickle cell disease, to identify acute and chronic complications associated with sickle cell disease, to select appropriate disease-modifying therapy for a pediatric patient with sickle cell disease, and to develop a treatment plan for a patient presenting with vaso-occlusive crises or acute chest syndrome. First, we're going to meet a patient RL, and we'll discuss him later at the end of our presentation, but I want you to be thinking about this patient throughout. He is a 3-year-old male who presents to clinic for his well child visit. He has a known history of sickle cell disease. He is 13 kilos and up to date on his standard childhood immunizations. His current medications include penicillin 125 milligrams twice daily, hydroxyurea 200 milligrams once daily, and ibuprofen as needed. We're first going to begin by reviewing some background information about sickle cell disease. Worldwide, approximately 300,000 babies per year are born with sickle cell disease. And in the United States, about 100,000 people are estimated to have the disease. This is about 1 in every 365 African American births and 1 in every 16,300 Hispanic American births. The prevalence is correlated to areas of high malaria risk as the sickle cell trait, so patients who are heterozygous for sickle cell, protects against severe malaria caused by Plasmodium falciparum. And you can really see that in the map on the right here. So in many African countries, about 10 to 40% of the population can carry a sickle cell gene. And obviously, if 2 parents were to have that same gene, their child would be at much higher risk for developing sickle cell disease. When thinking about the pathophysiology of sickle cell disease, it's important to think about hemoglobin. Hemoglobin is an iron-rich protein that carries oxygen from the lungs to the rest of the body. It's composed of 2 alpha globin and 2 beta globin chains. Sickle cell disease specifically is a homozygous mutation within the beta globin chain. It's a point mutation that causes a coating of valine instead of glutamate in position 6 of that hemoglobin beta chain. And so if a patient were to be homozygous, so have mutations in both genes, they would have a sickle cell disease. When we think about the pathophysiology a little bit more, we can think about our deoxygenated hemoglobin. So when our hemoglobin does not have oxygen on it, it's going to polymerize, and it can cause the red blood cells to lose water and cations. Those damaged red blood cells become sickled, and they're going to express abnormal lesions of adhesion molecules. Those sickled red blood cells have lower redox ratios than normal red blood cells, and this is ultimately all going to lead to hemolytic anemia, blocked small blood vessels, and vaso-occlusion. The red blood cell oxidative stress will also decrease oxygen delivery and induce red blood cell aging. And it's really important to think about and understand this pathophysiology, because if you can understand what's occurring to these red blood cells, a lot of the complications and therapies that we use for these patients will make more sense. Additionally, when we think about those deoxygenated hemoglobins being kind of that starting point for the sickling, we can think about our triggers for sickling. And some of these can include high altitude, presumably because of the lower oxygen levels, as well as infections and poor air quality. Here is a picture of some of the sickled cells. So you can see the top picture here is those normal red blood cells. They're going to be disc-shaped and easily move through blood vessels, carrying that hemoglobin. However, when we have that abnormal sickling of the red blood cells as a result of that deoxygenation, they're going to block blood flow through the veins, and that's ultimately what's going to be causing our complications. So those sickle-shaped red blood cells will get stuck in the blood vessels, leading to vaso-occlusive events, and ultimately decreased delivery of oxygen to our organs, such as our spleen, liver, and kidneys, which can cause damage and long-term complications. After recurrent episodes of sickling, we will start to see membrane damage, and the cells are no longer capable of resuming normal shape upon reoxygenation. So approximately 5 to 50% of red blood cells can remain permanently sickled. This is ultimately going to lead to a shortened red blood cell lifespan, which can of course lead to anemia. So for a healthy red blood cell, the lifespan is about 120 days. For a sickled red blood cell, it's only about 10 to 12 days. So sometimes these patients can require transfusions as well. When we think about sickle cell disease, you have that homozygosity for the sickle hemoglobin gene is our true definition of a sickle cell disease. Hemoglobin SS is generally the most severe form and the most common form of sickle cell disease. Patients who are heterozygous for this mutation can have different presentations. So hemoglobin SC is typically going to be a milder form with fewer complications. Hemoglobin S beta thalassemia can either be more mild or severe, depending on if it's beta 0 or beta positive. And then hemoglobin AS, so that's going to be patients who have one normal hemoglobin gene and one sickle cell hemoglobin gene. Those are going to be our sickle cell trait patients. So they're carriers of the gene, but they do not have clinical disease. Other less common genotypes of varying severity will include hemoglobin C, E, and D. Neonatal screening is mandatory in the United States for sickle cell disease. It's going to be performed on the umbilical cord blood or from a heel prick at birth. And any high-risk infant, so patients who have parents with a known history of sickle cell disease or sickle cell trait, so if they were not screened at birth, they should definitely be screened prior to 2 months of age. And this is really because early diagnosis allows for early treatment and control of disease. We can educate our families on sickle cell emergencies and have earlier interventions to prevent and minimize complications. Patients typically will not present until after 6 months of life if they were not diagnosed on that newborn screen. And that's because up to 6 months of age, patients will have elevated levels of fetal hemoglobin. That fetal hemoglobin binds oxygen more tightly than our normal hemoglobin and therefore is less likely to sickle. And so these patients are less likely to therefore have symptoms or clinical presentation of sickle cell disease. For those patients that do present with disease, some presentations include dactylitis, which is less common. It's going to be the swollen fingers, hands, toes, and feet. We can see some splenomegaly, a vaso-occlusive crisis or episode, a hemolytic anemia, and then organ damage from those microinfarcts. And that dactylitis is really going to be in our younger patients. We see it less commonly in our older patients. So now we've gone over some of the background on sickle cell disease. we're going to dive into some of the complications that these patients can have. So these complications can really impact all of the body systems, and it can be both acute and chronic. In our pediatric patients, we'll most commonly see things like splenic sequestration, a pain crisis or episode, and acute chest syndrome. Adult patients might have some of those same presentations, but often will also have some of those more chronic presentations, including chronic pain, long-term anemia, or CKD. Our new treatment approaches have definitely improved survival for these patients. However, the average lifespan remains about 2 to 3 decades shorter than Americans without sickle cell disease. And a lot of this is going to be due to some of those more chronic complications we see these patients are at risk for. So when we think about our acute complications, they can really all be tied back to ischemic tissue damage. So patients are often going to present in severe pain because part of their organ or their tissue is maybe not receiving good blood flow and good oxygenation. Patients may be more susceptible to infections, particularly if they have splenic sequestration, acute chest syndrome, priapism, and then cerebrovascular accidents. When we think about vaso-occlusive episodes, this is our primary presenting morbidity associated with sickle cell disease, and it causes hospitalization in about 95% of patients who are ill enough to present to the ED or primary care. The incidence of pain may have a greater impact on a patient's quality of life than organ damage does. And clinical consequences of these episodes include those acute chest syndrome, or hepatic and renal involvement, cerebrovascular incidents, as well as multi-organ failure. And they're really multifactorial in nature. So you're going to have that occlusion of the small blood vessels, but you can also have large vessel hyperplasia, thrombosis, bone marrow fat embolization, and AVN. When we think about our chronic complications, there's essentially 2 buckets here. You can have that large vessel vasculopathy or progressive ischemic organ damage. Within the large vessel vasculopathy, we can see cerebrovascular incidents, pulmonary hypertension, and retinopathy or blindness. And within the progressive ischemic organ damage, this is where we see some of that hyposplenism, renal failure, liver damage, bone disease, chronic pain, infertility, and cardiomegaly. So now that we know and understand a little bit more about the complications these patients can face, both acutely and long-term, we're going to discuss some of our important prevention and treatment options. So one of the most important things we can do for these patients is prevent infection. So 94% of patients by the age of 5 will have had vaso-occlusion of the spleen that results in functional asplenia. And we know the spleen is important for removal of our encapsulated organs, particularly in our children under the age of 2. So things like strep pneumo and Hep B. Strep pneumo infections in particular are important to recognize early as they can progress quickly and lead to death in 24 hours or less. We do see a decrease of these infections around the age of 5, and it's also important to note that we have vaccines to prevent strep pneumo, Hep B, and N-menenge. So making sure patients are up to date on these vaccines is a really important role of the pharmacist in care of our sickle cell disease patients. That leads us to our vaccines. So we have our pneumococcal vaccination. So our 13-valent conjugate vaccine, these patients should get 4 doses before the age of 23 months. And then for the 23-valent polysaccharide vaccine, we give the first dose at age 2 and the second dose at age 5, about 3 to 5 years after the first dose. You have your Hib and your meningococcal vaccine. So Hib will be standard to what we would do for other pediatric patients. And then for meningococcal, we can give Menveo or Menactra starting no later than 24 months of age. And we can consider Bexsero or Trumemba beginning at the age of 10. And of course, other annual vaccines like the flu vaccine and routine childhood vaccines are important. You'll notice I did not call out COVID vaccination, and that's really because those recommendations are still changing quite a bit, and I did not want to provide any inaccurate information. However, our providers do typically recommend COVID vaccination for eligible patients. Penicillin prophylaxis is another important piece of infection prevention for patients. So when we started using penicillin prophylaxis, we saw decreased rates of strep pneumo from about 3.2 to 6.9 events per 100 patient years to just 1.5. And because of that, it's really recommended to be used in all patients with hemoglobin SS disease. And I specifically say hemoglobin SS disease because if a patient were to have a different form, those recommendations may vary. In our patients under the age of 3, we'll recommend 125 milligrams twice daily. And once they hit the age of 3, it should be 250 milligrams twice daily. There is obviously some issues with compliance with that dosing schedule. The suspension is not stable for very long, and so it can be challenging for families to continually be picking that up from the pharmacy. And then anytime you're recommending a twice daily med, there's obviously room for decreased compliance. Generally, penicillin prophylaxis will stop around the age of 5, and that's because we see patients being a little less susceptible to infections at that age. However, if the patient has a history of a splenectomy or an invasive pneumococcal infection, it can be continued indefinitely or at the provider's discretion. And for penicillin allergic patients, we'll typically recommend erythromycin. When we think about our disease-modifying therapy, so more treatment, but also prevention of some of those vaso-occlusive episodes, hydroxyurea is standard of care and first-line therapy for all patients. It has proven efficacy in reducing vaso-occlusive episodes and improving patient survival. So the annual rate of a vaso-occlusive episode was found to be 44% lower than placebo and reduced mortality at the 9-year mark by 40% in patients. So because of this, we recommend its use in all patients over the age of 9 months to reduce the incidence of sickle cell disease related complications. In adults with multiple moderate to severe pain crises, pain that interferes with daily activities and quality of life, or severe recurrent acute chest syndrome, they are also recommended to be using hydroxyurea if they are not already on it. I did want to dive into the baby hug study just briefly. This is the only study we really dove into for sake of time. I do think it's quite important to highlight the great benefit we see with hydroxyurea for these patients. So the goal of Baby Hug was to assess the effect of hydroxyurea on organ dysfunction and clinical complications, as well as look at side effects associated with it. It was a randomized, double-blind, multi-center control trial, and patients received either hydroxyurea 20 milligrams per kilogram per day or placebo for 2 years. Patients either had hemoglobin SS or hemoglobin S beta thalassemia 0, and they were aged 9 months to 18 months at randomization, so that younger patient population. Of the 96 patients enrolled in the hydroxyurea arm, 83 completed the trial, and 84 of 97 in the placebo arm completed the trial. When looking at efficacy, they found that the hydroxyurea group, only 19 of the 70 compared to 28 of the 74 had decreased spleen function, so that was not statistically significant. And additionally, the difference in glomerular filtration rate, so looking at kidney function, was not statistically significant. When looking at our pain events, however, the hydroxyurea group had 177 events in 62 patients compared to 375 events in 75 patients. And this was quite significant with a p-value of 0.002. That dactylitis that we see in our younger patients, the hydroxyurea group had 24 events in 14 patients compared to 123 events in 42 patients. And then we also saw increased hemoglobin and fetal hemoglobin for these patients. From a safety perspective, toxicity was limited to mild to moderate neutropenia. So when thinking about a quality of life perspective and decreasing potentially long-term complications as well as pain events for these patients, hydroxyurea certainly had benefits with very few side effects, which is why we use it. Diving a bit more into hydroxyurea, it is a ribonucleotide reductase inhibitor. So it inhibits the hemoglobin S polymerization that would cause sickling, and it also is going to induce fetal hemoglobin production, remembering that that fetal hemoglobin is going to more tightly bind oxygen and thus be less likely to sickle. Additionally, it'll decrease circulating leukocytes and reticulocytes, and it alters the expression of adhesion molecules that contribute to that vasoocclusion. Metabolism ultimately causes a release of nitric oxide, and that might help with local vasodilation and also help prevent vasoocclusion. So you can see there's several things within the mechanism of hydroxyurea that can be quite beneficial for our sickle cell patients. When looking at our dosing, for our infants and children, we'll generally start at 20 milligrams per kilogram once daily. However, some providers may choose to start at a slightly lower dose of 15 milligrams per kilogram and then titrate up. For our adult patients, we will typically start at that 15 milligram per kilogram once daily, rounded to the nearest 500 milligram capsule size, and then increase in increments of 5 milligrams per kilogram per day every 8 weeks to a maximum dose of 35 milligrams per kilogram. With these patients, we can see mild cytopenias, and because of this, we'll watch their ANC and generally target an ANC of 2,000 to 4,000. So significantly higher ANCs telling us that patients are tolerating it well, and we're able to increase that dose, with lower ANCs telling us we may need to hold the dose and back down on it. There are no known transporter or metabolism concerns from a drug interaction standpoint. However, caution should be used if we're looking at other medications that can also cause neutropenias for these patients, and they may warrant closer monitoring. So it does hold a black box warning for that myelosuppression as well as secondary malignancy. Other adverse effects include vasculitic ulcerations, hypersensitivity reactions such as drug-induced fevers, macrocytosis, interstitial lung disease, infection, and neutropenia. And typically therapy will be held for any signs of toxicity and then resumed at the provider's discretion with potential need for dose adjustments. From a monitoring standpoint, at baseline, patients should have a CBC with differential as well as reticulocyte count. We should be monitoring the percent of fetal hemoglobin patients have, a CMP, and then pregnancy testing is important. The CBC with diff and retic count should be done every 2 to 4 weeks while adjusting doses for patients. And ideally, we want to see fetal hemoglobin increase to about 15 to 20%, ANC greater than 2,000, and platelets greater than 80,000. Once a patient's dose and CBC have been stable, you can move that CBCO diff to every 3 months. And then renal and hepatic function should be monitored intermittently to make sure we're not missing any sort of toxicity. From an administration standpoint, it's given once daily, and it can be given with or without food. And for patients unable to swallow a full capsule, a liquid suspension can be prepared. There may be issues with this, however, because it is a hazardous medication, and with the new USP guidelines, it can only be compounded at select pharmacies, and this can certainly be a barrier for families. That said, there is a new dosage form available. It's called Sickle, and this is a dissolvable pill for patients who are not able to swallow pills. So we can dissolve that Sickle in water if the patient can't swallow a pill and they don't have access to a compounded hydroxyurea suspension. The next disease-modifying therapy that we're going to talk about is voxelotor or Oxbryta. Voxelotor works by hemoglobin S polymerization inhibitor, so it's going to prevent that polymerization by reversibly binding to hemoglobin and stabilizing the oxygenated state of it. So if the oxygen cannot leave the hemoglobin, it can't polymerize, and we're not going to see that sickling. It is FDA approved in patients 4 and older with sickle cell disease, and it received accelerated approval based on increased hemoglobin levels demonstrated in the HOPE trial. And that continued approval is contingent on verification of clinical benefits. With the HOPE Kids study, we do now have that dosing down to the age of 4, and you can see it's dependent on the patient's age as well as weight. So for patients under the age of 12, we'll look at their weight and say if they're 10 to 20 kilos, look at 600 milligrams, 20 to 40 kilos, 900 milligrams. And if they're 40 or more kilos, look at the 1500 milligram dose. All patients over the age of 12, regardless of weight, will receive the 1500 milligram dose. And if patients have severe hepatic impairment, they should be dose adjusted to 1000 milligrams daily. From an adverse reaction standpoint, hypersensitivity reactions are rare but can be serious for patients. And things most commonly reported included headache, diarrhea, abdominal pain, fatigue, rash, nausea, and fever. When thinking about drug interactions, it is a minor substrate of several of our CYP enzymes listed there, and does weakly inhibit CYP3A4. There's some potential concerns about the true benefit of voxelotor, which is why its approval is contingent based on continued clinical efficacy. And really what that is that conformation change is not able to deliver high amounts of oxygen. So it's stabilizing the hemoglobin in that conformation that binds the oxygen, but then is the oxygen able to leave the hemoglobin to go to the cells that need it? Additionally, there's some concern that the increase in hemoglobin concentration seen by taking voxelotor does not necessarily decrease anemia for these patients, though certainly there has been some benefit seen, or else it would not have been approved. When looking at our monitoring parameters, we do want to monitor hepatic function. If you'll remember, we do dose adjust for severe hepatic impairment, as well as signs or symptoms of a hypersensitivity reaction. It can be administered with or without food, and the 500 milligram tablets must be swallowed whole. So it's primarily going to be your adult patients or those older than the age of 12. There are 300 milligram tablets available, and those tablets must be dispersed in at least 5 mLs of clear liquid at room temperature. So essentially you would disperse the tablets needed to achieve that patient's dose in a cup with room temperature clear liquid, so it can either need to be water or a clear soda, and that needs to be 5 mLs per 300 milligrams. So if it's a 600 milligram dose, it needs to be 10 mLs. You would swirl the contents of the cup until it's fully dispersed and disintegrated. And then, of note, there can still be small tablet clumps visible in the mixture. You just want to make sure it's not one big tablet still sitting there. You can continue to resuspend any residue that's left in the cup with the liquid as long as the patient's still drinking all of that, and continue to repeat that until all of the tablet has been administered. From a cost perspective, it is pretty expensive. So each 500 milligram tablet is about $140. And each 300 milligram tablet is just over $200. So for patients who don't have insurance coverage or do not have coverage for this medication, it can be quite cost prohibitive. Looking back at clinical application of this, so when we talked about hydroxyurea, we said we know this is first-line therapy. So for voxelotor, its exact place in therapy is still yet to be determined. So it's unclear the true clinical benefits. However, we did see increases in hemoglobin levels in patients. And there was a study at the end of 2021 that came out by Shaw and colleagues, and that did show a decrease in mean transfusions for these patients because of those higher hemoglobin levels, which of course is a potential benefit for these patients. In the studies, we did not see a significant reduction in vaso-occlusive episodes, though with increases in hemoglobin and blood viscosity, you may have actually expected to see more vaso-occlusive episodes, so not seeing a decrease could still be a positive sign. And then it's quite expensive for patients, particularly if they don't have adequate coverage. So that was voxelotor. Our next one is going to be crizanlizumab or Adakveo. It works by blocking P-selectin. P-selectin is an adhesion molecule that's expressed by our red blood cells, and it prevents it from interacting with P-selectin glycoprotein ligand 1 on our endothelial cells. And so we see less adhesion and therefore less occlusion. It is FDA approved in patients over the age of 16 to reduce the frequency of vaso-occlusive episodes based on data from the SUSTAIN trial. And it's dosed at 5 milligrams per kilogram IV every 2 weeks for 2 doses, and then you would continue that 5 milligram per kilogram dose every 4 weeks. When thinking about adverse reactions, infusion reactions are going to be one of the most significant ones we will see. So they're rare but can be severe, and we'll talk about that in just 1 second. Other reactions that we can see for these patients include nausea, arthralgias, back pain, and fever. For the infusion reactions, it's tempting to treat them with corticosteroids because they look so much like a hypersensitivity reaction. But it's important to note that steroids can cause an increase in rebound pain, and so steroids should not be considered first line for treatment of these infusion reactions. For these, they'll typically occur within 24 hours of the infusion and generally after the first or second dose. Patients can have pain, headache, fever, chills, nausea, vomiting, diarrhea, and pruritus, as well as dyspnea and wheezing. And to treat them, you want to slow or interrupt the infusion for a mild to moderate reaction, and then you can consider pre-medications and slower rates for future infusions. There are no known significant drug interactions, and the biggest monitoring parameter is really signs and symptoms of infusion reactions. For administration, it's typically administered over 30 minutes through a 0.2 micron inline filter, and it can be flushed with NS or D5. And it's only stable for 4.5 hours at room temperature. So if a patient has an infusion reaction, this is going to be something that's important to consider. How long has the medication been paused? How long has it been at room temperature? And how long do we need to run it over for to finish this dose? Or should we just resume therapy with the next dose? Vials do have to be stored in the refrigerator. From a cost perspective, it is also quite expensive. For a 100 milligram per 10 ml vial, the cost is $282 per ml. So for reference, a 50 kilo patient would have a dose be about $7,000. So again, if a patient does not have insurance, this can be quite cost prohibitive for them. So when we think about the clinical application of crizanlizumab, also not necessarily first-line therapy for these patients, and still working to figure out the specific place in therapy of crizanlizumab. Some benefits. So it's monthly infusions. So these are expensive, and coordinating them can be challenging for patients and families. However, if the patient's really non-compliant with their oral therapy, having them come to clinic for a monthly infusion could be beneficial overall. It is currently only approved in patients over the age of 16, so a lot of our pediatric patients are not going to be eligible, and using it off-label in a younger patient can be challenging due to issues with insurance coverage. And then there is a reduction in the annual rate of vaso-occlusive episodes, which is obviously a huge benefit for these patients. So a little more clear, I should say, on that clinical benefit here. So in the SUSTAIN trial, there was a 45.3% reduction in the annual rate of vaso-occlusive episodes for patients specifically receiving that 5 milligram per kilogram dose. All right, our next disease-modifying therapy is L-glutamine or Indari. So increased levels of L-glutamine are needed to synthesize NAD in our high-stress situations. And L-glutamine is going to improve that NAD redox potential of our red blood cells to help prevent oxidative damage. It is FDA approved to reduce acute complications of sickle cell disease in patients over the age of 5. And the dose is going to vary based on the patient's weight. So for patients under the age of 30 kilos, it'll be 1 5-gram packet twice daily. For 30 to 65 kilos, it's going to be 10 grams, which is 2 packets twice daily. And for patients over 65 kilos, it'll be 15 grams or 3 packets twice daily. It was not studied in patients with renal or hepatic impairments. They do recommend using it with caution in that population. And other adverse reactions include chest pain, headache, flatulence, constipation, nausea, abdominal pain, limb pain, back pain, and cough. From a drug interaction standpoint, lactulose is the only known interaction, with it showing decreased efficacy of the lactulose. And because we didn't study it in renal or hepatic impairment, we do want to monitor our renal and hepatic function in these patients. From an administration standpoint, they recommend preparing it immediately before administration by mixing with 240 mLs of cold or room temperature beverage, or with 120 or 180 mLs of food. So quite a lot of volume for some of our patients to be taking. Of note, complete dissolution is not required prior to administration. Again, from a clinical application standpoint, there are several key things to be thinking about. So pharmaceutical grade versus over-the-counter powder. Currently, only pharmaceutical grade is approved patients may find much cheaper product over the counter. So I was looking and found a 1,000 gram container, which is about a 30-day supply depending on the patient's dose, for $27 on Amazon. And this is something that comes up pretty frequently where patients may be able to afford over-the-counter product, but they don't have insurance coverage for the Indari itself, and they want to know if they can try the over-the-counter product. And so really, from our standpoint, what we do is we look at that product that they're asking about, make sure it does not include any other ingredients, and we really recommend using the FDA-approved form, but letting them know that, you know, this product is not necessarily going to hurt to try. I just can't say it's going to be as beneficial as that FDA-approved form, and that's specifically because that FDA-approved form of L-glutamine consists of a different isomer than what's available over the counter at nutrition stores. Insurance coverage. So many insurance companies will not cover Indari for patients, and even if they do have coverage, copays can be pretty expensive with this medication, so cost prohibitive here as well. Additionally, adherence is going to be really challenging for these patients. So we mentioned that even penicillin prophylaxis can be challenging for compliance. Well, this is a chalky white powder for which patients have to take a large volume of liquid and a large amount of the powder itself. They generally do not enjoy that. Though if you can mix it with a preferred beverage or cool food, it may help improve that compliance. And then when we compare it to hydroxyurea, which is still really our go-to first line for patients, it is a non-chemotherapeutic agent, and so some families may prefer something a bit more natural and ask to try this product first. And so patients are not willing to be compliant or are unable to be compliant with their hydroxyurea. It could be an option. So comparing these new therapies, I want to note here specifically that not only do we not know exactly when to try each of these therapies for patients, and a lot of that's going to depend on patients' ability to afford the medication as well as their age and the FDA-labeled dosing for that. But using these therapies in combination with one another was really not studied. So most of these studies did allow for the use of hydroxyurea as long as patients were on stable doses at the time. However, we don't have studies saying what's it look like for a patient to be on hydroxyurea, voxelotor, and L-glutamine. And so what that combination looks like is really an unknown that remains to be answered. For voxelotor, some pros: it does increase hemoglobin levels in our sickle cell disease, and we have at least one study showing that those increased hemoglobin levels will decrease transfusion requirements. However, if it provides any other clinical benefits, such as decreasing vaso-occlusive episodes, is unclear at this time, and it is expensive. For crizanlizumab, it reduces the annual rate of vaso-occlusive episodes. However, it's very expensive. It's only approved in patients over the age of 16, and those patients are at a risk for increased pain during and for 24 hours after that infusion reaction with those infusion reactions that we see. And so that can be a big downside for patients. And then finally, L-glutamine. So pros of this therapy include that it decreases rates of vaso-occlusive episodes as well as acute chest syndrome and sickle cell disease, and it's more affordable than the other options, though definitely still expensive. However, it is taken twice a day, and it is a chalky white powder, making adherence and compliance with it challenging. So those are some of our pharmaceutical treatment options. I now want to briefly talk about some of our non-pharmaceutical treatment options. And one of this is going to be our blood transfusions. Blood transfusions are life-saving in our vaso-occlusive episodes and splenic sequestration, and they can reduce the risk of stroke in our high-risk patients and lower the incidence of vaso-occlusive episodes. However, patients receiving chronic blood transfusions can have excessive iron storage leading to iron overload. They can have alloimmunization to the blood, and they can also have hyperviscosity, which could potentially increase that patient's risk of a vaso-occlusive episode. When we think about treatment of acute complications, transfusions certainly have a role in these. So for treatment of acute episodes of anemia, transfusions are going to be appropriate for most situations characterized by acute exacerbations of anemia. So if their hemoglobin has dropped 1.5 to 2 lower than that patient's baseline, a transfusion would certainly be appropriate. We also can look at transfusions for raising the oxygen carrying capacity of blood to decrease the proportion of sickled red blood cells. This can provide symptomatic relief and minimize complications from a hemolytic crisis. And then when we're doing this, we want to carefully dose it back to that patient's baseline value. So about 10 mLs per kilo of packed red blood cells will increase hemoglobin 1 to 2 grams per deciliter. And so we really don't want to overshoot that patient's baseline if we can avoid it. That's going to help us minimize that risk of volume overload. And then just noting again that hyperviscosity can occur if the hemoglobin concentration is increased, particularly greater than 11 grams per deciliter. And we want to avoid hyperviscosity because we can see a slow flow through small blood vessels with that hyperviscosity, and that can result in additional sickling and trigger or worsen a vaso-occlusive episode. So while blood and hemoglobin that is not sickled can certainly provide benefit to these patients, there are some drawbacks, and we just need to be very judicious in the transfusions we're providing to patients. When we think about primary stroke prevention for children with an abnormal blood flow velocity, so this is going to be detected using a transcranial Doppler ultrasonography, and that Doppler ultrasound basically enables evaluation of the cerebral arteries' blood flow velocity. So if the patients have abnormal blood flow velocity, routine blood transfusion should occur every 3 to 4 weeks for at least 1 year if feasible. After 1 year of therapy, hydroxyurea can be considered as a substitute for these patients. And with these transfusions, our ultimate goal is going to be a hemoglobin S level greater than or less than 30% and a hemoglobin level greater than 9. The stroke prevention trial and sickle cell anemia study, or the STOP study, does recommend that yearly Doppler screening should be done for children with sickle cell disease between the ages of 2 years and 16 years, with repeat within 3 months for children with abnormal results. So those are those patients that would be getting the primary stroke prevention transfusions. For patients who have had a stroke and we're looking at secondary stroke prevention, we would use blood transfusions for goal, the attaining hemoglobin S levels less than 30% and hemoglobin greater than 9. And then if a patient has a suspected or confirmed stroke, a prompt blood transfusion is recommended at the first recognition of symptoms, and then exchange transfusion is suggested over simple transfusion when possible and when neurologic deficits are present. However, these chronic transfusions are not without their complications. These include infection, volume overload, and hypersensitivity reactions, as well as iron overload, which will typically occur when a patient has received a cumulative dose greater than or equal to 150 mLs per kilo of packed red blood cells. For these patients, iron chelation may be required. So both deferrazerox and deferoxamine are approved in pediatric patients, and then deferriprone is now approved in pediatric patients down to the age of 3. All of those come with significant benefits and risk and should be chosen based on patient-specific factors. Now that we talked about some of the treatment options for the disease itself, we're going to dive into some of the complications we can see with sickle cell disease and how we can treat those. Our first one's vaso-occlusive episodes. So this is, again, our most common complication of sickle cell disease, and it's the top cause of ED visits and hospitalizations. It can occur as early as 6 months of age, and they recur predictably over a lifetime of a patient. This is really significant pain resulting from tissue ischemia caused by vaso-occlusion, and triggers of this include dehydration, exercise, emotional states, cold and warm temperatures, hypoxia, and infections. So for patients presenting with acute pain, rapid, within 1 hour assessment and administration of analgesia with frequent reassessments is recommended. For these patients, they will often not have an IV at presentation, and we can consider using medications like intranasal fentanyl to help rescue their pain while we're working to obtain that IV access. We also want to provide individualized opioid analgesia for these patients. So we can base this on baseline therapy, so what's their outpatient analgesic use look like, as well as prior effective therapy. Many of these patients may prefer Dilaudid to morphine or vice versa based on past experiences. And they should also be offered a continuous PCA or around-the-clock scheduled opioids during an episode. We want to reassess their pain every 15 to 30 minutes until it's well controlled, and then continue regular assessments once it's been controlled. For treatment, we can also consider adjunctive sub-anesthetic ketamine. So this can be recommended for pain refractory to or not effectively treated with opioids. We'll typically start patients around 0.1 to 0.3 mg per kilo per hour with a maximum dose of 1 mg per kg per hour. Commonly, we'll see adverse effects at doses greater than 30 milligrams per hour, and so our institution at least will often cap at that rate, even if it is not the 1 milligram per kilogram per hour that the patient could go up to otherwise. And those adverse effects include hallucinations, dysphoria, tachycardia, and sedation. Of note, the definition of refractory here is left to the clinician in the guidelines, and so that may vary significantly institution to institution. For adjuvant therapies, we can think about acetaminophen and NSAIDs. So it can be more useful in our mild to moderate pain in place of opioids and in conjunction with opioids in severe pain. So using it early is probably going to be more beneficial than just adding it on, though it can certainly act synergistically to improve pain control with opioids. We should not use NSAIDs in patients who have end organ damage, especially if it's kidney failure or retinopathy. And then we can think about some non-pharmacological therapies for these patients as well. So our guidelines suggest the use of massage, yoga, transcutaneous electrical nerve stimulation, virtual reality, and guided audio-visual relaxation as potentially beneficial for patients. Heating pads, hot packs, hot baths, or showers can be beneficial, but ice may exacerbate some of this pain, so it can vasoconstrict, and so generally recommended to stay away from that. And then encouraging distraction and coping mechanisms for all patients can be beneficial. For these episodes, fluids are important, so IV plus PO at 1 to 1.5 times maintenance can be helpful to prevent overhydration, which can precipitate or exacerbate acute chest syndrome, but also make sure patients are well hydrated. If the patient is believed to be dehydrated at baseline, or if there is believed to have increased insensible losses, you could do a higher rate. And then antiemetics to prevent any nausea, making sure patients have an appropriate bowel regimen to prevent constipation, especially since they'll be on scheduled opioids. And then if a patient were to have opioid-induced pruritus, using low-dose intermittent nalbuphine or a naloxone continuous infusion can be very beneficial. And then thinking about some of those things like diphenhydramine or hydroxyzine may still help. So that is our vaso-occlusive episodes. The next complication we'll talk about is our acute chest syndrome. So this is a common and serious complication in our sickle cell disease patients. It's the second most frequent reason for hospitalization and can precipitate uncontrolled episodes of a vaso-occlusive episode. It is the most common cause of death, and it accounts for about 25% of sickle cell related deaths, and it's also a risk factor for stroke. Patients can be diagnosed with this with a new pulmonary infiltrate on a chest x-ray, as well as fever, chest pain, and signs and symptoms of pulmonary disease such as tachypnea, cough, dyspnea, or hypoxemia. Generally, it resembles pneumonia, and it can develop suddenly or insidiously. Pulmonary problems like asthma or pneumonia can certainly worsen it because local or systemic hypoxia will then increase sickle hemoglobin polymerization. So some of those etiologies again are going to be that pulmonary vaso-occlusion, pulmonary infarct, fat embolism, vaso-occlusive episode, any sort of anesthesia or surgery, as well as infection. And treatment is really going to be first with a broad spectrum antibiotics. So generally we'll prefer ceftriaxone. The medications like cefotaxime or cefuroxime could be used. If a patient has a cephalosporin allergy, levofloxacin is an option, or meropenem. If the patient is believed to be at risk for atypical microorganisms, adding azithromycin can be important. And then you can consider vancomycin in patients who have a severe illness. If they have a large infiltrate with pleural effusion and Staph aureus is suspected, or if they have a history of strep pneumo infection. For other treatment options, we want to maintain euvolemia. So fluid overload can lead to pulmonary edema and increased respiratory distress for these patients. And so preventing that is really important. You can consider methylprednisolone if wheezing or rales are present or if there's a history of reactive airway disease. However, the therapeutic role of corticosteroids and other anti-inflammatory agents is really uncertain and requires further investigation. So it's associated with a quicker time to recovery, but these patients are also at significantly higher risk of rebound. And so to decrease that risk of rebound, even if it is a short course of steroids, you can consider tapering them off, even though we would not standardly do that for a patient without sickle cell disease. Additionally, there has been a brand new study published at the beginning of 2022 showing an increased risk of vaso-occlusive episode after exposure to systemic steroids. So again, there are a lot of benefits that we see with steroids in our general patient population, but really need to be cautious and judicious when using them in our sickle cell disease patients. And then incentive spirometry can be really beneficial for these patients to help keep those lungs open. So things like marshmallow shooters, if your hospital has them, can be fun ways to engage our little kids. And then finally, blood transfusions. So these can help improve the oxygen carrying capacity in patients with symptomatic acute chest syndrome if their hemoglobin is greater than 1 below their baseline. However, if that baseline hemoglobin is normal for them, blood transfusions may not be required. So that was acute chest syndrome. Next, we'll move into some fever considerations for these patients. So for patients with sickle cell, if they present with a temperature over 38.5 at home, it is considered an emergency and families should bring them in right away. Basic laboratory evaluation is recommended, so doing things like a CBC, obtaining a chest x-ray, looking at their O2 sats, and then doing blood, urine, and throat cultures as applicable. These patients are at increased risk of severe bacterial infection because that reduced or absent splenic function. They're particularly at risk for those encapsulated organisms. So that'll primarily be due to strep pneumo, and that risk is especially high in our pediatric patients, though it'll lessen in our adult patients. Additionally, there is concern for patients presenting with acute chest syndrome or osteomyelitis, and so ruling these out is important as well. When thinking about outpatient versus inpatient management for patients with fever, if the child is non-toxic appearing, they have a fever less than 40 degrees Celsius, they've never been septic, and they have a normal chest x-ray and O2 sats, as well as normal baseline CBC, you can consider giving ceftriaxone IV once for those patients, and then follow up in 24 hours. So it covers those patients for strep pneumo and H flu for 24 hours. And if they're clinically stable after those antibiotics, it'd be reasonable to send them home as long as you feel that they are a reliable family that will come back if the patient deteriorates and will come back for further assessment the next day. If the patient looks toxic at all, if they have infiltrates on their chest x-ray or abnormal O2 sats, if their white blood cell counts is elevated or low platelet count or low hemoglobin, or if they have a history of sepsis, admission to the inpatient service is recommended. So those are some of our big complications and how we can handle them for our sickle cell disease patients. I briefly want to touch on some of our options regarding cure for sickle cell disease. And I will say this is not a deep dive into any of these topics, and I would encourage you to do your own research if you are interested in them. So transplant is our only cure for sickle cell disease at this time. Approximately 95% of patients who undergo stem cell transplant are cured of their sickle cell disease. However, due to complications associated with transplant, only a small portion of patients will actually undergo transplant. And it's typically those who have this more severe manifestation, such as recurrent acute chest syndrome or vaso-occlusive episodes, if they have any sort of osteonecrosis or sickle nephropathy. Ideally, a patient would have a matched related donor. However, due to the inherited nature of sickle cell disease, only about 8 to 10% of patients have such an eligible donor. So our best outcomes are associated with HLA matched related donors and our younger recipients, so transplanting patients when they're younger as opposed to older adults or teenagers. There was an international study that included 1,000 HLA identical sibling transplant recipients, and they did find that age was a significant risk factor. So the 5-year overall survival for patients over the age of 16 was 81%, compared to those under the age of 16 was 95%. Additionally, we do have emerging data on safety and efficacy of transplant from alternative donors that's promising, and so this is certainly an area that's going to continue to grow and expand for these patients. Additionally, we have gene therapy options for patients. So this is going to be genetic manipulation, so deletion, insertion, or modification, where we'll delete the hemoglobin S mutation or increase fetal hemoglobin production through silencing a repressor of that fetal hemoglobin production. They'll receive a myeloablative conditioning regimen followed by infusion of manipulated autologous stem cells. So when we talked about transplant just a minute ago, that was from somebody not related or somebody else other than that patient. These patients will collect their cells, they will be genetically manipulated, and then they'll receive those cells back. And we know anytime a patient undergoes an autologous transplant, there's fewer complications as opposed to receiving it from somebody that is not themselves. These clinical trials are really new and they're ongoing, and so there's a paucity of data right now and we definitely need more studies to establish the durability of response and safety and efficacy of these therapies. All right, so that was the major points in this presentation, but I did want to briefly review some key concepts with you all. So our first one, acute and chronic complications of sickle cell disease can be explained by its underlying pathophysiology. Sickle cells decrease oxygen delivery to tissues and can lead to infarcts in the tissue. Hydroxyurea is first-line therapy for all children over 9 months old with sickle cell disease, and newer therapies for sickle cell disease include voxelotor, crizanlizumab, and L-glutamine, though their clinical relevance varies and the role of combining these new therapies is unknown. Prompt treatment to pain episodes is key for our patients with sickle cell disease, and the goal is opioid therapy in less than 60 minutes on presentation to the ED. Infections are a leading cause of childhood mortality in patients with sickle cell disease. Penicillin prophylaxis until age 5 and staying up to date on vaccinations is important. And if a patient has a fever, they should present for prompt evaluation. Finally, transplant and gene therapy are evolving and they offer potential cure for sickle cell disease. So next we'll go back to our patient RL. He's our 3-year-old male who presents to clinic for his well-child visit, 13 kilos and up to date on standard childhood immunizations. His current medications are listed there for you. Our first question, which of the following forms of hemoglobin are protective against complications? Is it A, hemoglobin C, B, hemoglobin F, C, hemoglobin S, or D, hemoglobin beta thalassemia? And I'm going to give you guys about 20 seconds to think about that. If you need longer, please pause the presentation. Great, the answer here is hemoglobin F, or fetal hemoglobin. Question 2. Based on RL's medical history and current medication list, which of the following recommendations do you want to make at his clinic visit today? I will let you read through those and think of your answer. I'll give you guys about 45 seconds before showing the answer, and if you need longer, please pause the presentation. Great, the answer here is C. Since he's now over the age of 3, we want to increase his dose of penicillin to 250 milligrams twice daily. Additionally, if he's not started his meningitis vaccine schedule, we want to recommend either Menveo or Menactra today. Question 3. His labs come back and his CBC and CMP are within normal limits. Today his ANC is 5,000 and his platelets are 100,000. Which of the following would you recommend? Again, I will let you read through these answers and I'll give you about 45 seconds to do so and choose the correct one. If you need more time, please go ahead and pause the presentation. Great. The correct answer here is B. So we want to increase his hydroxyurea dose to 260 milligrams once daily. We'll recheck his ANC and platelets at that time, and if they remain stable in approximately 8 weeks, we'll consider another increase by about 5 milligrams per kilogram per day. Question 4. RL presents to the ED in significant pain, rating it 8 out of 10, after playing outside in the snow for several hours. What's the most appropriate pain management strategy? Again, I'll let you read through these and I'll reveal the answer in approximately 45 seconds. Great. The correct answer here is B. Quick management is essential for patients. We want to do this in under 1 hour. We should consider a dose of intranasal fentanyl while IV access is being established. Question 5. RL presents in respiratory distress. Chest x-ray and labs consistent with acute chest syndrome. He doesn't have rales or wheezing noted on auscultation. Other than antibiotics, what therapy can you recommend? Again, I'll give you 45 seconds to look through this. B and C are the most correct answer here. So we want to encourage pain control and recommend opioid analgesic if his ibuprofen is not controlling the pain. Additionally, we should encourage incentive spirometry. Starting steroids for these patients is quite controversial, and we have nothing in RL's history to suggest that he has reactive airway disease that might benefit from the methylpred more than the harm potentially steroids can cause in our sickle cell patients. With that, here are my references. And thank you all so much for tuning in today. I hope you found this presentation to be quite helpful.